the organizers for this opportunity to talk on the workup of a patient of heart failure. The patient is a 65-year-old diabetic, hypertensive, smoker, obese, male with increased breathlessness who was on treatment for COPD. The workup includes, based on the clinical settings, the judgment by the physician, available resources, and available technology. Comparing the symptoms of COPD and heart failure, though the many symptoms are common, the presence of cough, frequent respiratory infections, presence of sleep apnea, and chest tightness are found in COPD, whereas those with congestive heart failure have more of palpitation, have got chest pain, and frequent urination at night. Even physical examination, though there are many similarities between COPD and congestive heart failure, presence of wheezing and cyanosis with mild dyspnea categorized as COPD, whereas the presence of heart murmur, fetal edema, and enlarged neck veins, they are found in congestive heart failure. The association between cardiovascular disease, risk factors, and chronic pulmonary disease on mortality shows a significant relationship between COPD and heart failure, with the hazards ratio of 1.3 to 1.9. In the presence of comorbidities in COPD, 20% of COPD patients have heart failure, and the other accompaniments like hypertension are found up to 40% of patients with COPD. And patients with hospitalized patients with heart failure, the prevalence of COPD is between 10 and 39% depending on the study. So after a diagnosis of heart failure is made by criteria of Framingham's or by the Boston criteria or the ESC criteria, what we do is first we start with a routine laboratory test with the CBC electrolytes and the renal function. And the CBC is used for the assessment of anemia. The leukocyte shows the infection. Iron deficiency has to be assessed because 1/3 of heart failure patients have iron deficiency, which contributes to poor function and worse outcomes of it. And the transferrin saturation greater than 19.8 or iron level of 13 micromole has the best results in identify patients with iron deficiency who will respond to treatment. Renal functions in patients with severe heart failure, particularly those with large dose of diuretics, may have increased urea and creatinine, and they require controlled diuresis. It is important to also monitor the electric disturbance of sodium and potassium. Liver function, there may be raised bilirubin enzymes in congestive hepatomegaly in acute RV or LV failure. Frank jaundice and the picture may resemble viral hepatitis, and the important thing is respond once the heart failure response is also improves. Natriuretic peptides are important to differentiate between the cardiac and non-cardiac cause of dyspnea. They are directly proportional to the ventricular volume and pressure overload. It is very important to remember they are higher in older people, men, women, and patients with renal dysfunction, sepsis, and atrial fibrillation even in the absence of heart failure. So they may be disproportionately low in patients who are obese, hypothyroidism, end-stage heart failure, but its NT-proBNP is a better marker for detecting cardiac dysfunction because it's very sensitive and is more clinically stable. The upper limit in a non-acute setting is for BNP and NBNP are 35 and 125, acute that is 100 and 300. So biomarkers are useful in all stages of heart failure for prevention, diagnosis, prognostication, A, B, C, D, acute, hospitalized, all categories. The next is to do the ECG, which is abnormal in 98.2% of cardiac failure patients. The majority have got more than 3 abnormalities. Most important thing is LVH, and we find LA in patients with reduced EF and tachycardias. And these other ECG abnormalities, STT changes, IVCT, all occur. And very important to know about arrhythmias that can add to the prognosis and contribute to disease in the form of tachycardia, cardiac myopathy. And in a special group of patients with less than EF and LVB and symptomatic status, in spite of guided directed medical therapy, may benefit with devices. Holter also may be used in select cases. It's also next common investigation which is found in practice in X-ray. A systematic approach, we look at the vascular pedicle, increased heart size, pleural effusion, redistribution of fluid, azygous veins, pulmonary edema, and curly B lines. And there's a correlation between pulmonary capital width pressure and the distribution of pulmonary vasculature. There's a redistribution which occurs in 13 to 18, interstitial edema 18 to 25, and alveolar edema which occurs more than 25. One important measurement is the vascular pedicle width, which is made the distance between where the SVC joins the bronchus and where the subclavian artery leaves the aorta. The distance between the two is the vascular pedicle width. Normal is less than 60, anything more than 70 may signify cardiac failure and renal failure. This is a patient with classical X-ray of a patient shows an increased VWT width is increased as well as increased bronchial. You see the increased vascular markings in the upper lobe more than 2 millimeters, but left with respond to treatment, most the vascular width and the vasculature comes down. This is the artery bronchus ratio. The upper lobe 0.85, lower lobe 1.35. In the mid zone is 1:1, but in this picture, you see near the hilum, the artery is significantly higher than the bronchus, which shows as a congestion. When you look for pleural effusions, let us see the lateral view because only 75 ml is required to see the lateral view, whereas if you want to see a PA view, 175 ml is required. Next is look at the curly B lines we see in the right perpendicular to the chest wall. They indicate interstitial edema, interstitial accumulation of fluid, and then the frank pulmonary edema in the form of autumnal appearance. We also have situations in which there is a subpulmonary collection of fluid. Distance between the funded gas chamber and the diaphragm increases. And then we also look at the azygous vein. Any azygous vein in the erect filling more than several millimeters indicates congestion. And then the CT in the dependent areas showing more congestion due to hydrostatic pressure. It's also pathognomonic of cardiac failure. RV failure, you look at the dilatation of azygous veins, right atrium, IVC, hepatic vein, and SVC. And measurement of right atrium, the SVC few millimeters before joining the right atrium, and anything which is more than 21 millimeters and collapse less than 50% correlates the right atrial pressure of about 20 millimeters. Echocardiogram is a gold standard structure for the structure, functions, diagnostic, prognostication, and also for volume measurements of atrium and ventricular musculature, and also for finding out key functional alterations in the form of E prime, E by E prime and central lateral wall, E dash velocities. So it also indicates the etiology of heart failure. It's very important to know in heart failure when the stable patient becomes unstable, there's a period in which there's an asymptomatic of hemodynamic and pulmonary condition. When there's a frank Starling law, the blood pressure rises and stress-induced B lines are seen, followed by B lines at rest, then later translating into dyspnea weight gain. This period, which takes 2 days to weeks, can be picked up with the ultrasound, which we take a 4-point rule, which is marked as per the markings in the picture, and we use a 3.5 to 5 hertz probe, and we see the anteriorly and laterally, and what is these patterns of A lines, the right side B lines, the pleural effusion and consolidation, and also irregular pleural line. And this classical B line which is seen with this comet tail appearance, if there are more than 3 B lines per space, intercostal space, bilaterally signifies congestion and cardiac failure. Coronary angiogram is in selected patients for angina pectoris, recalls to medical treatment, symptomatic VT, aortic arrest, systolic dysfunction, unexplained cause, or episodic heart failure with normal systolic function, and patients with heart failure, interval probability of CAD, and if you have the probability of ischemia on exercise testing. Right heart catheterization, very important information about filling pressures and resistance, but mostly it's used when we are planning for device therapy or heart transplant. Other tests like cardiac stress test, radiography, ventriculography, MRI, endomyocardial biopsy are used in selected settings, and cardiac MRI is used for ischemic, non-ischemic, infiltrative, hypertrophic, and viability. It's used for congenital heart disease, valvular heart disease, and for right or RV function. It's very important to predict the success of revascularization and should be used in patients where revascularization is planned. Genetic testing is doesn't have no definite confirmed role for routine testing, but in 3 types of categories, DCM, HCM, autosomal dominant ARVD, still got a role to play. The functional capacity and exercise tolerance are categorized 3 ways. One by the NYHA functional class by the patient. Second is a direct measure of cardiopulmonary testing by the peak VO2. And third is the 6-minute walk distance, which is inexpensive test and well tolerated by the patient. The prognosis in patients with reduced ejection fraction has got a correlation with the mortality, non-fatal cardiovascular and hospitalization. It's very important to know that for favorable effects of morbidity and mortality, 30 to 50 meters distance is enough, whereas inclusion quality of life, 80 meters will be needed. So you always correlate the other parameters like systolic function, cardiac index. In normal range of 6-minute walk distance is 400 to 700, and there's an inverse correlation between distance and NYHA class. But it's very important to know the dose with preserved ejection fraction did not correlate with the measures obtained from CPT, and the functional capacity in this population has been challenged. Whereas in patients with reduced ejection fraction, the information is very similar to the peak oxygen uptake as done in the pulmonary function testing. Conclusion: heart failure diagnosis can pose challenges for even the experienced hands. The first step in workup of heart failure is to establish a diagnosis and stage of heart failure. Once we stage the failure, we need to evaluate the patient for reversible factors, controllable factors, and look for the patient's accompaniments and comorbidities. Optimal utilization of resources available in the setting the patients being treated. Referral to higher centers for higher care device-based therapy like device therapy in CRT, ICD, and heart transplant for appropriate cases may be needed. The poor prognosis and huge disease burden gives the opportunity to alter the course with guideline-directed therapies that has increased the responsibility of treating physician to work up the patient well. Thank you very much.
Good evening. I would like to thank the organizers for giving me this opportunity to speak on subject title Obesity and Heart Failure. As we know that obesity is an emerging epidemic of health problems globally. About one third of the global population is either overweight or obese. And if you see the trends of incidence of the obesity, we find that it is increasing faster in the low-income countries compared to the high-income countries. The, it is estimated that 26 million patients world over are having heart failure. Heart failure is the commonest cause of hospitalization and mortality in elderly population. Obesity increases the risk of heart failure and contributes about 11% of the heart failure in males and up to 14% in females. We diagnose obesity based on the body mass index, but it is important to realize that body mass index is contributed by fat mass and fat-free mass. And then muscle mass constitutes the major portion of the fat-free mass. Based on the BMI, it is very difficult to identify the phenotype of obesity, whether the obesity is due to sarcopenia or because of it is non-sarcopenic obesity. The heart failure in obesity is of multifactorial in etiology. It is related to ischemic insult, related to tachyarrhythmia, which are often seen in patients with obesity. The atrial fibrillation is the commonest tachyarrhythmias. And it is also related to alterations in the loading conditions of the myocardium, mediated by activation of the neurohormonal system, which affects the central as well as the peripheral hemodynamics, resulting in structural remodeling of the myocardium. So in obesity, there are diverse mechanisms through which it leads to increasing risk of developing heart failure. The relationship between the obesity and risk of heart failure has been studied in Framingham Heart Study, where 5,881 participants who are free of heart failure at baseline, followed for 14 years, where 496 subjects developed heart failure. When the data was analyzed in relation to the baseline BMI categories, it was seen that incidence of heart failure was highest in obese, overweight population compared to those with normal body weight in both genders. The meta-analysis of number of observational studies also document the same J-shaped relationship between the body mass index and the incidence of heart failure. Heart failure incidence increases as the body mass index increases. Now the question comes, is the intentional weight loss in obese subject, can it decrease the risk of heart failure? There are no controlled clinical trials to answer this research hypothesis. However, the observational studies have done in patients with obese population in Sweden, the SOS cohort, where 4,033 obese subjects who were free of heart failure at baseline, and those who underwent bariatric surgery from the intervention arm, and those who did not undergo bariatric surgery for intentional weight loss from the control cohort. And these subjects were followed for 22 years, and the results showed that there was a significant reduction in the weight as expected in the surgical group compared to the control arm. And the incidence of heart failure was decreased by 35%, which was statistically significant in the surgical group. And the risk reduction in the incidence of heart failure was seen across all subsets of the study participants. Now, the question comes, is the intentional weight loss in patients with established heart failure with obesity, will it effectively reduce the mortality or not? Because we have seen that obesity is an important risk factor, and losing weight helps in preventing the risk of developing heart failure in obese population. Again, this question of the safety and efficacy of weight loss in obese heart failure population has not been studied in controlled clinical trials. However, there are the systematic review and meta-analysis of number of studies trying to look at the all-cause mortality in different age groups, different BMI groups reported significant increase in the mortality in the underweight heart failure population compared to the reduction in mortality seen in heart failure population with the overweight and obese. However, in a morbid obesity subgroup, although there was a trend of decreased mortality, but it was not statistically significant. So what could be the reason for this survival advantage of obese heart failure population compared to their counterparts? So there could be potentially a number of reasons. One could be greater metabolic reserves. Obese heart failure patients are less cachexic. They are protected from cytokines, and they present early, and the harmful effects of RAS is attenuated. And normally these patients have high blood pressures, so tolerance to the guideline-directed medical therapy is better than their counterparts, and they are from the diverse etiology. However, there exists a skepticism about the validity of this observed obesity paradox, because these are based on the retrospective analysis of the observational studies, where the clinical profile of patients with heart failure with low BMI is completely different from patients with heart failure with high BMI. So low BMI may be marker of severity of heart failure than the risk factor for increased mortality. And also in patients with low BMI with heart failure, because their blood pressure is in the lower side, there is a suboptimal use of guideline-directed medical therapy, which also may contribute to higher mortality rates. When the data was analyzed about the survival rate amongst the different BMI groups of heart failure patients, adjusted for baseline cardiopulmonary fitness, the patients of heart failure, those who had good cardiopulmonary fitness at baseline, there was no obesity paradox was not seen on the right side. And on the left, you see that patients, those who had poor cardiopulmonary fitness at baseline, the survival advantage of high BMI was observed, and patients with low BMI, the survival rate was significantly low. So therefore, suggesting that even if the weight is low in heart failure patients, if their baseline cardiopulmonary fitness is better, there is no increased risk of heart failure mortality. The impact of intentional weight loss with lifestyle intervention was evaluated to assess its effect on the physical fitness and mobility in patients with overweight and obese diabetic in the age group of 45 to 75 years in one of the controlled clinical trial by the Look Ahead Research Group. And patients were randomized to intensive lifestyle intervention, which included caloric restrictions, moderate intensity physical activity, and in the control arms, they were provided education and diabetic support. And patients were followed for 4 years. And it showed that the physical fitness was significantly higher in the intensive arm, while compared to those in the control arms, and also hemoglobin A1 level was significantly reduced in the intensive lifestyle arm. In the self-reported mobility, proportion of patients reporting good mobility was significantly higher in the lifestyle interventions compared to the sport arm. However, the secondary outcome of all-cause mortality and non-fatal myocardial infarction and stroke, there was no difference. So it suggests that physical activity as well as the caloric restriction as a lifestyle intervention is beneficial in overweight and obese population in improving the quality of life. Based on these available evidences, the guidelines recommend weight loss in heart failure patients, those who have morbid obesity, and those who have less than 35 BMI. Weight reduction is not advised. However, the exercise is prescribed in all patients with heart failure if their physical symptoms, if the symptoms of heart failure permits the physical activity in order to improve the quality of life and the physical fitness. So I would like to conclude by saying that obesity is a global public health problem which increases the risk of heart failure, and in obese population, reducing weight is beneficial in reducing the risk of heart failure. And lifestyle intervention is beneficial in obese patients for improving the mobility as well as the physical fitness. However, we lack evidence to evaluate to know the clinical benefit of weight loss in obese patients with heart failure. Therefore, we need large controlled clinical trials for evaluating the safety and efficacy of weight loss in obese heart failure patients for reducing the risk of mortality and worsening heart failure, which are important adverse outcomes seen in patients with heart failure. So with these, I would like to thank for your kind attention.
Good evening. At the outset, I would like to congratulate the Heart Failure Association of India, Dr. Hari Krishnan, Dr. Abraham, and Dr. Sundar for organizing such a wonderful conference. Heart rate control in patients with heart failure is very important. But first of all, we need to understand what is a heartbeat and what is heart rate in patients with heart failure. A single heartbeat ejects about 89 ml of blood in a normal heart. In a day, that amounts to about almost 30 kg of ATP being expended. In a living creature, the heart can beat for a finite amount of time. It can beat a finite number of beats, and that is going to be fixed. If the hummingbird's heart can beat at 600 beats per minute, it lives only for 5 months. Whereas the turtle has a heart rate of only 6 beats per minute, lives for almost 150 years. So ultimately, the beats will remain about 500 million beats. And if you plot the various heart rates of various living creatures, you get a curve like this. The mouse, the hamster, the rat have fast heart rates. They live short lives. The whale, the elephant, the horse, the lion have relatively slower heart rates, so they live longer. Coming to the humans, if you look at data from the Framingham database, what you find is that for both the younger men and the older men, the mortality increases as the resting heart rate increases. So if you look at this data, both for the younger age group less than 64 and above 64, as the heart rate goes from 30 to 67 to above 92, the mortality per thousand keeps increasing. Coming to patients with myocardial infarction, there are studies which have shown that increased heart rate at discharge is sometimes even a better predictor of mortality than ejection fraction. And if you look at data from the SHIFT study, you find that patients who had a higher heart rate above 75 had worse outcomes as compared to those who had rates below 60. So heart rate does play an important role as a prognostic marker. So what does heart rate do? Heart rate does a lot of things in patients with various cardiovascular disease. Increased heart rate will cause atherosclerosis. It will cause an increase in the oxidative stress, can destabilize the bra. It can cause arterial stiffness. The tachycardia itself can cause tachycardia, cardiomyopathy. It can, in a failing heart, increase the oxygen demand. It can reduce the ventricular efficiency. It can cause remodeling, which is adverse and can cause cardiac hypertrophy. By increasing the oxygen demand, reducing the diastolic period, it can cause ischemia. So just an increase in the heart rate can cause all these diverse problems. It is a prognostic marker, but it has also now become a therapeutic target. This started in the 1990s when it was realized that the initial attempts at using beta blockers to reduce the heart rate were misguided in one concept, that the doses that were being given were very high. So we started using lower doses in patients with heart failure and then started titrating them. And these were some of those landmark trials. You are aware with all of them. I won't go into the detail. The CBIS 1, CBIS 2, MERIT, COMET, Seniors, all these trials moved along with the ACE inhibitor trials and proved that along with ACE inhibitors, the beta blockers also have a role in managing heart failure, and reducing the heart rate also has a role in reducing the long-term mortality in patients with heart failure. But as the trials progressed, we realized that it is not sufficient just to give or prescribe beta blockers. You would find that overall the heart rate control was not adequate. Patients in the trials were not having adequate heart rate control. There were lots of patients in whom the heart rate was still very high in spite of being prescribed beta blockers. And what was the reason? The reason was that majority of patients were not actually reaching the target dose of beta blockers that had actually been found to be beneficial in most of the initial trials. So only 18% of the patients reaching the target dose, only 47% of the patients reaching at least 50% of the target dose. So actually this is the reality also, that very few patients actually get the target doses of the beta blockers. And as I said, the heart rates in most of these trials are much higher than what we normally target or want to target. This is the data that if you look at the various studies, recommended dose, for instance, carvedal is 50 milligrams, metoprolol is almost 200 milligrams. The actual doses that are being given, this is in a Euro survey, 17 milligrams of carvedal, 75 milligrams of metoprolol. Even in our own data from India, this is the data from our patients at the point of discharge after acute heart failure episode, they receive only about 4 milligrams of carvedal, possibly because that's what they're tolerating. Data from our patients in the clinic when they just enter the heart failure clinic, data from the Trivandrum registry also shows that only 25 to 50% of the patients are actually getting recommended doses and recommended medication. Only half of them are getting beta blockers. Then came another new drug. This is ivabradine, attacking the funny channels. And this was the SHIFT trial. I won't go much into the detail. The SHIFT trial, it also had Indian patients, 92 patients from India, total more than 6,000 patients across 37 countries, more than 600 centers. I'll just highlight some of the essential points of this trial which are relevant to my talk today. Basically, these were patients who had class 2 to 4 heart failure, but the essential thing is that they were systolic heart failure. They had a heart rate which was above 70. So these are patients who had relative tachycardia, their heart rates were high. They had been recently admitted for heart failure. That itself makes them a relatively sick subgroup of patients. And they were very well managed patients, 90% on beta blockers, 84% on ACE inhibitors, and more than 60% on aldosterone antagonists. So very well managed patients. Put on ivabradine or placebo for 3 years. Primary endpoint, composite of cardiovascular death and hospitalization for heart failure. Simple trial, very well managed patients. And what do we find? Ivabradine reduces death from heart failure, especially in patients where the heart rate was high. So if the patients have heart failure, there is tachycardia, adding ivabradine on top of a beta blocker reduces the death from heart failure. So it does not matter whether the patient was on a beta blocker, it does not matter what dose was the patient on beta blocker, but it did matter that if there was tachycardia, these patients definitely benefited. The more the tachycardia, more the likely to be, the benefit was likely to be there. So we basically find that adding a beta blocker makes a difference. Adding ivabradine causes much more benefit. So then there were trials to see where else can ivabradine work in patients with heart failure. The beautiful trial looked at patients with coronary artery disease and LV dysfunction. It found that if you give ivabradine to all patients with CAD, there is no benefit. But if you give it to patients with CAD who have LV dysfunction and they have a heart rate of above 70, these patients are likely to benefit. So if you have CAD with LV dysfunction, you have to have tachycardia also, then these patients will benefit. But if they don't have tachycardia, the benefit will not come. So basically we're coming to a point where ivabradine is going to work if there is tachycardia only. Without tachycardia and LV dysfunction, it's not going to make a difference. Then came the Signify trial again, ivabradine in CAD without clinical heart failure. And what did they find? No benefit of ivabradine in reducing cardiovascular events in patients without clinical heart failure. So it is a marker of risk, but it is not a modifiable factor in patients without clinical heart failure. So if you have patients with CAD without heart failure, it is not a factor which can be modified to the extent that it makes a difference in long-term outcomes. Any talk on heart rate can actually not be complete without talking about atrial fibrillation. It's not the scope of my talk, so I'll just mention it in very brief. The question of rate versus rhythm is still wide open. I will not go into this. Lots of trials have been there. Mortality rate was not really better overall with rhythm control. It's difficult to maintain sinus rhythm. Rate control is much easier to maintain, but antiarrhythmic drugs are improving. Catheter ablation techniques are improving. The future may go towards rhythm control, which obviously gives much better cardiac output, gives much better quality of life in the long term. So the question is still open. So to summarize, drugs like ivabradine will reduce readmissions due to heart failure in patients who have resting heart rates above 70, ejection fractions which are low, and in patients who have heart failure which is because of reduced ejection fraction and who have heart rates which are fast, drugs like ivabradine will reduce mortality due to heart failure and heart failure admissions. What are the ESC guidelines? The ESC guidelines say that drugs like ivabradine should be given to patients with heart failure due to reduced ejection fraction who have tachycardia. And beta blockers should be given to all patients with heart failure with reduced ejection fraction. There is no question about giving it to patients with tachycardia or no tachycardia. So beta blockers to all, and if in spite of beta blockers there are patients who still have some tachycardia or who can't be given beta blockers, then you add ivabradine. So that's the current guidelines also. So to conclude, the elevated heart rate is a risk factor in cardiovascular disease, especially in patients with heart failure and tachycardia. It's a modifiable risk factor for LV dysfunction and increased heart rate. Beta blockers are a must for heart failure. However, up titration to target dose remains a long-standing challenge. A complementary approach, beta blockers and ivabradine provides a much better tactic in order to achieve the target heart rate and has proven benefits. Thank you, and I'm ready for any questions if there are any. Thank you very much.
Good evening, respected seniors and dear friends. At the outset, let me thank Dr. Abraham Umman for giving me this opportunity to discuss the importance of fluid, salt and diet in the outpatient management of heart failure. The 2016 ESC guidelines on heart failure clearly states that decompensation of chronic heart failure can occur without any precipitating factor, but more often with a non-adherence to diet. So what are the dietary components of importance to us? There are actually three. One is fluid intake, second is salt intake, and third is alcohol. As it is easy to discuss the third one, as the recommendations are clear, I jump to alcohol. It is a complete no in alcohol-induced cardiomyopathy. They should abstain from taking alcohol. In other heart failure patients, the normal alcohol guidelines apply. That is 2 units per day for men and 1 unit for females. We all agree that fluids and salts are to be restricted in heart failure. This is the general dictum. If we go to the guidelines, ESC 2016, the statement is a little vague. You avoid excessive fluid intake and restrict fluid to 1.5 to 2 liters per day in patients with severe heart failure to relieve the symptoms and congestion. Individualize fluid intake based on the body weight of the person and give advice to increase the intake during periods of high heat and humidity as well as nausea and vomiting. During periods of acute decompensation, you adjust the advice and probably withdraw from them or increase them. Consider altering these restrictions towards end of life of the patient. The ACC AHA guidelines of 2016 almost agrees to this. A fluid restriction of 1.5 to 2 liters is reasonable in stage D patients, especially those with hyponatremia, to reduce congestive symptoms. And the ACC clearly states that Routine strict fluid restriction in all patients with heart failure, regardless of the symptoms or other considerations, does not appear to result in significant benefit. If we go back to the ESC of 2008, they almost agree with the ACC. Fluid restriction of 1.5 to 2 liters per day may be considered in patients with severe symptoms, especially those with hyponatremia, and a routine fluid restriction in all patients with mild to moderate symptoms does not appear to confer clinical benefit. What about the salt intake? ESC 2016, avoid excessive salt intake, that is more than 6 grams per day, so slightly more than 1 teaspoon. 6 grams of salt converts to 2.5 grams of sodium. Well, is there any evidence to support these guidelines? I searched far and wide, but I could not find much, and whatever I found was often contradictory. A very old paper, 1994 JAMA, which looked at the management of heart failure. They reviewed the studies published in English between 1966 and 1993. So probably all the old studies were put together in patients with reduced ejection fraction of 35 to 40%. And the first consensus opinion evolved that in patients with mild to moderate heart failure, restrict sodium to 3 grams per day initially, and if they are unresponsive to this dosage, or those who have more severe disease should be advised to consume 2 grams per day or less. In 2004, there was another paper published in Nutrition which looked at the effects of a nutritional intervention in heart failure patients. What was this intervention? Sodium restricted diet, 2 to 2.4 grams per day, and a strict restriction of total fluids to 1.5 liters per day. They found that the edema and fatigue was significantly less, while the functional class and physical activity showed significant improvement in this group of patients. In 2018, there was a review article in JAMA which looked at the reduced salt intake for heart failure, a systematic review. They pulled out 2,655 references concerning the salt intake, but to their surprise found that only 9 studies actually could be included. They were only of sufficient quality to be included in the review. So the rest had so many problems and they could not be included. Only 479 total participants, and none of these studies had more than 100 patients. Even in these 9 studies, there was significant disparity. Some suggested improvement, while others no improvement in the NYHA functional class by restricting the salt intake. So finally, rather than giving a guidance on the amount of salt to be taken in, this paper said there is paucity of robust high quality evidence to support or refute the current evidence. A yes or no they cannot say. A well-designed, adequately powered studies are needed to reduce the uncertainty about this intervention. Well, do we have current trials for this? We have. The Gourmet HF, the Sodium HF, and the Prohibit Sodium are ongoing. The pilot studies of all these 3 big trials have already been published with small number of patients. Let us have a quick look at their pilot studies. The Gourmet HF actually looked at patients discharged from hospital after heart failure getting a home delivered, patient doesn't have to go and buy, a home delivered sodium restricted DASH diet of 1.5 grams of sodium per day versus usual care. Well, this appeared safe even in the geriatric subset and had directionally favorable effects on the clinical status and 30-day readmissions. The Sodium HF compared a low sodium 1.5 grams versus moderate sodium 2.3 grams diet. And the conclusion was that restricting to this levels was feasible. This was associated with lower BNP levels and improved quality of life. The Prohibit HF also looked at 2 aspects of sodium intake, 1.5 versus 3 grams. And both diets reduced urinary sodium without any adverse safety signal and while maintaining the quality of life. Well, these 3 trials are ongoing and we have to wait for their final conclusions. However, if you look at all the studies, you find that the benefits attained by fluid and sodium restriction has little effect on the mortality of the patient. Probably it decreases the hospital readmission at a cost of excessive thirst and loss of palatability of the diet, which could lead to poor intake, especially in elderly, leading to cardiac cachexia. One has to overcome the problems of fluid and salt restriction in the OP department. Excessive thirst we can overcome by judiciously spacing the fluid intake, and loss of palatability by changing the diet, by changing the low sodium diet very often to new one, which often requires the involvement of a dietitian. A doctor alone cannot do this because dietary monitoring periodically is required, dietary advised reinforcement periodically is required, which can be done by the dietitian. So summarizing what I have been speaking for the last few minutes, dietary adherence is important in outpatient management of chronic heart failure. And all of us agree that excess fluids and sodium should be avoided by all heart failure patients. A strict restriction of fluid and sodium should be advised to selected subsets and not routinely to all, selected subsets of heart failure patients. The selected subset include those with severe symptoms of congestion, breathlessness or edema, those with hyponatremia, and those with diuretic resistance. And restriction means fluids to the tune of 1.5 to 2 liters per day and sodium to the tune of 2.5 grams per day as the current guidelines stand. This may change. This may change with the results of the large trials coming in. And a team effort is required, and dietitian should be an important part of the heart failure management team. So thank you for the patient listening.
Thank you all the speakers for keeping the time and having the presentation. So we will start the discussion from Dr. Karunadas. So thank you for emphasizing the point that routine fluid restriction is not important, and it doesn't have any mortality benefit, especially in patients who are in class 2 or not having an acute decompensation. So in a practical point of view, how will you advise patients to restrict the salt? What are the can they have the salt which they usually add in the side dishes, or how do you advise them? Or to avoid the salts with excess salt content. So how do you practically do that?
Hari, if we look at the Kerala diet where we are meeting the patients, excess salt is present in pappadam, achar, and dry fish, what we call as onakamansya, dry fish. So first I advise them to avoid all these 3 things, pappadam, achar, and dry fish as far as possible, and reduce the salt that they are using in the curries. And some people in Kerala actually put salt when they are boiling rice. That practice is also to be avoided. That is the usual thing that I advise, and it is easy for the patients to follow. If they are not improving, then I ask them to have a separate diet for this particular patient, because usually at home a common diet is cooked, which is taken by all. So a separate diet with less salt or stringent restriction is advised. But very often practically it is difficult to do so.
Thank you. Professor Iyengar, any comments?
Yeah, we had 4 excellent talks with great clarity in the depth they deserve. And Dr. Karunadas, I think you made one point about alcohol, and I would like your comment as well as Dr. Sandeep's comment. Any amount of alcohol, they say, of recent reports, will increase the risk of atrial fibrillation. So would you like to tell no alcohol at all for all heart failure patients? And also would like Dr. Sandeep's comments on that.
Personally, I would like to say no to all, no alcohol to all heart failure patients. But if somebody is very particular that he should have a small amount of alcohol, then as per the guidelines, they can take, especially if it is not due to alcohol-induced cardiomyopathy. So personally, I would like to say no.
No, the point is that if we allow them to have alcohol, it has many deleterious effects like increasing the heart rate and leading to negative effects. So I prefer to say no to all heart failure patients unless they're going on insisting that to continue taking alcohol. Especially in Kerala, it will be difficult to restrict people from totally abstaining from alcohol. But I advise all my patients to totally abstain from alcohol. Sandeep
Even I advise the same. In fact, on all my OPD cards on the right, there's a small little note about each patient, what he eats, drinks, smokes, and all his habits. So don't realize that each time they come, I start by asking them, have you stopped smoking? Have you stopped drinking? What work are you doing? Are you back from Hyderabad? Are you back from there? So they don't realize that all the information about them is actually written quietly on the card. So I know that they are drinking alcohol, they're not stopped. And I ask the wives. So all the information is actually there. So I'm very clear that no alcohol. Because you can't, as Hari said, you can't really control anything.
Yeah.
So if you say yes, next time they'll say the doctor said yes. So they'll abuse that yes and take any amount. So it's better to just say no.
What we
Kannan, please.
Kannan sir, just 1 second. Dr. Negi, can we reduce one light? It's a little too bright on you, sir. Thank you.
Dr. Kannan, please.
Yeah. See, the problem with advising patients is very very dicey, in fact, because we say some things. There are some patients who are even a small any infection or even a small atrial fibrillation can trigger the balance the other side. Many other patients with heart failure will just carry on. These patients, we advise them two things. One thing, preventable things are smoking and alcohol. And of course, I also tell them to avoid tea and tea and coffee, because we don't want even that small thing to be provoked. But there are many patients who say that they have been taking alcohol daily. So when I tell them abruptly to stop, they have some amount of resistance. So we say you just confine to one peg in weekends or something, and then slowly we ask them to withdraw that also. But in patients with heart failure, if you ask me as a scientifically, yes, I would say that you must stop, abstain from alcohol completely, totally, and immediately.
Any other comments regarding this?
Sandeep, may I request one of your expert comments on this field? Use of digoxin to control heart rate in atrial fibrillation patients in heart failure.
I actually am a fan of digoxin. I use digoxin a lot, not only in atrial fibrillation, even otherwise. Many of my patients are on digoxin, so I see my protocol would be I would start all my patients on ACE inhibitors and diuretics. Moment they're becoming stable, I would add a beta blocker. But if they're not becoming stable, I would straight away start them on half a tablet of digoxin straight away. So I would start my patients on digoxin pretty early if they're not stabilizing. And atrial fibrillation, definitely, as long as I can stabilize their potassium and if their kidney function is fairly okay. And even if the kidney function is not fairly okay, I would put them on a very low dose of digoxin and keep an eye on the digoxin levels. Since we have digoxin levels available, I think digoxin is very useful for controlling AF heart rate. We just have to keep an eye on side effects.
Sandeep, you prefer digoxin to be started before ivabradine in patients in sinus rhythm. So
No, ivabradine will work with beta blockers. So ivabradine will follow its own path.
No,
heart rate control, I would use ivabradine along. No, for heart failure.
Indian patients, you start on digoxin or ivabradine. That is my.
Now, see, ivabradine will not control the symptoms. Ivabradine and beta blockers are for long-term mortality benefit. See, as far as the way I believe is for symptom management, the drugs are vasodilators and diuretics, ultimately maybe digoxin. For long-term mortality benefit, it will be vasodilators, beta blockers, and ivabradine. So there are two different pathways that we have to follow, and they work simultaneously. We have to work in the beta blocker ivabradine pathway is a slow pathway where you have to move slowly, carefully. The vasodilator and diuretic and ultimately towards digoxin is a faster pathway where you have to move very fast. That's how I work.
Want to move faster towards the SGLT2 inhibitors probably?
I've started putting some of these patients on SGLT2, but if you look at the trials, the SGLT2 inhibitors worked more in class 2 and 3 patients. They didn't work, there wasn't much of data on class 4 patients. So
can I ask
probably have to start earlier in these patients.
Yeah, Karunadas.
Sir, are you using half tablet of digoxin every day, or some people prefer to give 5 days a week and stop for 2 days, something like that?
I start half a tablet. It's simpler to have compliance.
Every day?
Every day.
Yeah, I also follow like that, half a tablet every day so that there is no confusion. Yeah. And half a tablet, we rarely see any digoxin toxicity in the patients.
Don't see.
We don't see at all, yeah, very, very rarely. Regarding Dr. Negi, Dr. Negi, your video is not visible. Video is not on. Regarding coming to Dr. Kannan, coronary angiogram in patients in the Indian setting, do you think that we should have a low threshold in doing that?
Because see, whenever if you see the indications of coronary angiogram I mentioned, one of the indications is when you are not able to find out a real cause of a cardiac failure. If you have a LV dysfunction and you like to do some, the threshold is really low basically in India. What we do generally practice is we almost do for all cases of DCM unless you think there is real strong cause for some other factor or reversible factor. So the threshold is already low, and even the indications worldwide also the any DCMP where the cause you are not sure, it's almost like that. So I think we are almost in that same threshold.
This presentation, Dr. Kannan, is an excellent coverage. What I would like to probably add is in taking history, you should also ask the history of certain drugs. For example, this patient is on steroids, there is a patient of COPD, is on steroids, then beta energetic drugs. Most of them, they go on inhaling salbutamol and their heart rate is so high. So we have to keep those two things in mind.
Yes, I just because the case that was given to me with COPD, so I thought I should have a comparison between the two and take towards the heart failure and then look up the workup. So that is where we went actually, because that's why I just want to tell you that COPD association is not just by chance. If you see the studies that have come, 20% of the COPD are cardiac failure. And if you see COPD patients, hazard ratio of heart failure and hazard failure of hypertension, hazard failure of the other risk factors, atrial fibrillation, are anything above 2 on 1.5 to 2. So it shows that it is all a spectrum. So the COPD adds up to everything. And if you say isolated heart failure is 20, but if you take other risk factors, promoting atrial fibrillation, promoting the other factors, we see the risk may be much higher than what we really know. And the basis of the studies of heart failure have shown the COPD is there up to 10 to 39% in patients who are hospitalized for heart failure. So this is a very important association which I want to emphasize. And moreover, I want to say about the ultrasound of the chest because it's very simple. A 20-second is just a workout for when you have patient comes to dyspnea. I just have to place the probe in the space and see for the curly B lines which are there. And is there it takes you directly towards heart failure, whereas COPD that is ruled out. And the pneumonia also can be followed up. This I thought I just emphasize these two in this lecture because it's only for 10 to 12 minutes.
Yeah, Dr. Negi, you were speaking about obesity, but on the other side, frailty is coming as a big marker of the outcomes in heart failure. So, can you comment on that? You are muted. Yeah, please unmute. Please unmute.
No, Dr. Negi, you are muted, sir.
Muted.
Sir, you are muted. Need to unmute yourself, sir.
You are muted.
So just press the space bar.
No, he's got some issues with the internet with that his end, sir.
Oh.
And just move the cursor on the screen, then.
Sir, you carry on. I'll help him on the phone, sir.
Okay.
Okay.
So what I was telling is that frailty is emerging as a marker, and compared to all other markers available, frailty is emerging as one of the most significant predictors of outcomes in heart failure. That is what I was going to stress.
We have in fact added frailty to our transplant assessment because you realize that there is no point transplanting frail patients. So we try to emphasize that frail patients will not be transplanted. We try to improve their frailty status before we even list them for transplant now.
Yeah, and it is very simple to measure also.
Yeah, it's actually very simple.
Very simple. You don't require any costly equipment, only that hand grip meter is required, and you other criteria.
Yeah.
Dr. Negi, regarding your comments on frailty.
Yeah, I was just talking about the the frailty. Basically, I think is an indicator marker of severe heart failure, because patients who are severe, heart failure, their mobility is restricted because of the limitations in the exercise because of severe heart failure. So therefore, their muscle mass, muscle strength is low. So that's why in these observational studies, the mortality related to the BMI, people with heart failure with low BMI are the ones who had a high mortality rate. So one of the things is probably people who have failed, their exercise capacity is low, and they generally probably they are basically markers of severe heart failure. So frailty, I would think, definitely is a marker for severe heart failure, and that's the reason for increased mortality. Whether improving the muscle capacity in these patients, because muscle strengthening through exercise will improve the outcome, I think this is the area which needs to be studied.
Yeah. Yeah, so I think we are reached the end of our allotted time. So, Dr. Iyengar, final words from you, and we'll close the session.
Thank you very much for those excellent talks by all our colleagues, and we learned quite a lot, and I'm sure we'll be able to manage heart failure better. Thank you.
Thank you so much, and we will go to the next session. Anand, please.
Yes, sir. Thank you, sir. We move on to the next